Welcome to the She Found Motherhood podcast. Today, we are talking with Dr. Genevra Mills, who is a reproductive endocrinologist and infertility specialist at Olive Fertility here in Victoria, BC. We are talking all things infertility and what are the causes of infertility, both on the female side and on the male side. And we also talk a little bit about unexplained fertility. Really great conversation today with Dr. Mills and excited to get to it right after this quick reminder.
Welcome to the She Found Motherhood podcast. We are doctors Sarah and Alicia, maternity physicians and moms who have been through it all. We want to empower you with knowledge so you can have the best pregnancy, birth, and postpartum experience you can.
She Found Health and She Found Motherhood is meant for general medical information only. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. This information does not apply to every situation. If you have questions or if you've received different advice, please contact your healthcare provider. Always seek the advice of your physician or another qualified health provider with any questions you may have regarding a medical condition. The views expressed by She Found Health and She Found Motherhood and our guests are not representative of any of the institutions with which we are affiliated. Some of our podcast episodes are sponsored so that we can keep getting great info out there to you, our listeners. We only partner with companies that we truly believe in. Some of our links and suggestions may be affiliates, and we would appreciate you using them to help fund this important work. Now let's get to it.
Welcome to the She Found Motherhood podcast. Today we are on episode 2 of our 3-part series on fertility with Dr. Genevra Mills. As you guys heard last week, Dr. Mills is a specialist. She's a OBGYN with a special training in reproductive endocrinology and infertility, and she has just joined us in the lovely Victoria, BC, and is starting out at the Olive Fertility Clinic, which has just opened its new location on Yates Street. So anybody who wants to check them out, head on over to their website, Olive Fertility Victoria location. Today, we're talking a little bit about what are causes of infertility. So as you'll remember, last podcast, we talked a little bit about what infertility is, and you all learned that I learned something new in the definition of infertility. We learned a little bit about how infertility changes as we age in both people with ovaries and people who produce sperm. And we also chatted a little bit about how we can get a sense from our body whether or not we're still ovulating on a somewhat regular basis. Genevra, thank you for joining us today. Why don't we get into it?
Sounds good. Thank you so much for having me back again. I think it's really important to talk about the causes of infertility. Sometimes we see people who have an obvious cause for why they're not getting pregnant. And oftentimes these can be identified before they even show up in our office. And so it falls on the lap sometimes of the family practitioner or the nurse practitioner or naturopath or whoever their primary care physician is to recognize some of these things. But most times patients have an idea that something's going on even before they get to that point of 12 months of trying without success. So I'm really excited to talk about these. And I find that this is one of the most impactful conversations I have with patients in the office.
Awesome. So what do you want to start off with? Shall we talk a little bit about kind of the medical conditions that can affect fertility?
Yeah, I like to start talking about just what we look for when we're looking at if you were to come in with no idea what's going on. We break down causes of infertility into 3 large categories. And this is when we look at couples. So you have a woman and a man who come together and we're looking at them in that situation. The 3 main areas, one of them is ovulation. So do we have an egg that's being released every month? And there's multiple reasons why there may not be an egg released every month. But this issue of ovulation makes up about 15% of a couple's cause of infertility. Another thing that we look at is the tubes or the uterus or the sort of the pelvic anatomy of the person who has the uterus. And if there's a problem with the way the fallopian tubes work, there's a problem with the uterus, or there's something wrong with the pelvis, so there's been surgery before, there's some reason for there's scar tissue or something in the pelvis, this accounts for about 30 to 35% of the reasons couples don't get pregnant. And then problems with the male partner or the person with the sperm accounts for between 35 and 40% of the reason why couples don't get pregnant. And these really range from there just being decreased sperm, there could be no sperm, there could be sperm abnormalities. And so when you add all of those together, there's a little sliver of the pie that doesn't fit there. And we those are people who fall into, or couples who fall into what we call unexplained infertility. And that's about 10 to 15%. And unexplained infertility is when we have an egg that is being released every month. We have normal or near normal sperm, and we have at least one fallopian tube and a normal uterus. We can sometimes break that off to look at when we look at just women or people with ovaries. And when we look at that part, we take all the male stuff out. Problems with ovulation make up about 40% of a reason why a woman might have difficulty getting pregnant. And problems with their tubes or their uterus or something else in their pelvis make up about 40%. And then that leaves the rest as unexplained.
Awesome. Thanks for breaking that down. Yeah, I didn't realize the unexplained infertility was quite that high. Nor did I realize that the male factor infertility was quite that high either. So why don't we chat a little bit about kind of the ovulation issues. So the issues that might affect a ovulating person to ovulate or not. Because first things first, we need to get an egg ovulated or follicle
Yes, for
ovulated,
sure.
right?
As I had mentioned in the previous podcast, when we look at menstrual cycles, having a regular menstrual cycle is 97% predictive of releasing an egg every month. And so if you're having a period that's anywhere between 25 and 35 days every, you're most likely releasing an egg every month. So most people who menstruate fall into that category, and we can say, usually we can check the box if that's the case. When you're not regularly having a period, so either you're having bleeding that's less than 24 days or you're having bleeding that's more than 35 days, there's some often things that we know to look for right away. The first and most common ovulatory dysfunction is polycystic ovary syndrome. And this is a little bit counterintuitive, but it's when your ovaries have lots and lots of follicles in them. And basically what happens is all of those follicles compete with each other. It's almost like too many cooks in the kitchen. They're all yelling at each other, and as hormonally and signaling wise. And as a result, nobody actually gets up and ovulates. And so that's the general simplistic version of what PCOS is. Some people already know they have PCOS even beforehand. Some people have no idea. There's some other less common ovulatory issues, and these have to do with what we call the hypothalamus or the pituitary gland, which are glands in your brain that are responsible for talking to your ovaries and telling your ovaries to do what they do. And these are usually most often ruled out by using blood tests. But if you don't have a PCOS and there's something else going on, sometimes the next thing we do is we look at these hormones that are produced by the hypothalamus and the pituitary to see if there's that sort of problem. Other things we look at are thyroid issues. So if you have a history of thyroid, either hypothyroidism or hyperthyroidism, so if you've had something like Graves' disease or Hashimoto's thyroiditis, those are, and now you're not having regular periods, sometimes looking at your thyroid hormone is important. And then also if there's a family history of premature ovarian insufficiency, so this used to be called early menopause. So if people's mothers or grandmothers had early menopause, sometimes and now you're not having regular periods, that's something to consider. Just to go back to that, when I was talking about those glands in your brain, the hypothalamus and the pituitary gland, sometimes there's things about your lifestyle that can give us some hints that might be the case. And so sometimes disordered eating or overt eating disorders, being a very active person. So if you're like, especially competitive sports, if you're excessively exercising or have a significant deficiency in how much you're eating versus how much you're exercising, being under a lot of stress can reduce this, and also having some systemic illnesses. So just being sick, it doesn't necessarily have to be something serious, but if it's enough to put your body under stress, then those are reasons why people would have difficulty ovulating.
Awesome. Thanks for reviewing that. And you have a special interest in PCOS, I do believe.
I do have a special
And
interest.
Sarah and I did a podcast on PCOS, and just a very basic one on PCOS and fertility. So if anybody is interested in learning a little bit more, then we'll put that in the show notes below and make sure to check it out. And then maybe we can get Dr. Mills to do a more advanced version of PCOS and fertility with us in the future.
I look forward to it.
Awesome. Okay, so we've talked a little bit about medical conditions around that can affect fertility. Why don't we talk about more structural, or these are kind of things to do with your tubes, ovaries, or uterus that might affect your ability to get pregnant?
Yeah. The biggest cause of tubal factor infertility, what we call when there's a blockage in your tubes, is actually having a history of sexually transmitted infections. Chlamydia and gonorrhea are very nasty little creatures. They like to infect, and they sometimes don't like to tell people that they've infected. And it's really important, really, that if you're having unprotected sex, that you're having your being screened regularly for sexually transmitted infections, because a lot of times you could have chlamydia and gonorrhea and not even know it. And in this entire time, it's going in there and it's wreaking havoc inside your uterus and inside your tubes and causing scar tissue. If you had a history of a sexually transmitted infection in the past, whether it was treated or not, that should be a little red flag that this could be something that needs to be ruled out. The more often that you've had a sexually transmitted infection, even if it's been treated, each incidence in your past increases your risk of having scarring in your tubes. This is mostly because, like I've said, a lot of people can have asymptomatic infections. So just because you all of a sudden got symptoms of a sexually transmitted infection doesn't mean that it just happened. You could have already had it for a couple of months before you started showing symptoms of it. So a history of sexually transmitted infections is usually a bit of a red flag for tubal factor infertility. Having had other pelvic inflammatory infections, so if you've ever had a pelvic inflammatory infection in the past, where you've had a tubal ovarian abscess that's been treated, those are other big risk factors. Also having endometriosis, especially if it's severe endometriosis where you've had, that can definitely distort your anatomy in terms of either causing scarring in your tubes or just making it so that your tubes are not necessarily in the right position in relation to your ovaries. Another issue is any type of surgery in your belly, or if you've had a ruptured appendix. So if you've ever had any type of operation, so if for your bowel surgeries, hernia repairs, anything that's gone inside your belly basically is a risk factor. And like I said about a ruptured appendix. So some people, they say, oh, I never had surgery, but I did have a really bad ruptured appendix and I was in the hospital, I had antibiotics, and these are things that we look at. Any type of abdominal surgery. And then related to that is your like inflammatory bowel disease.
Yeah. And the reason that this all happens is because these infections cause a lot of inflammation and scarring and glomming down of things. So I do a lot of assisting with gynecology and general surgery, and it's quite amazing at how much scar tissue and how much kind of distortion of the anatomy, like you said, can happen that people don't even recognize. They're not necessarily uncomfortable from it. It doesn't hurt, but it's just the scarring and how things heal up can really change your
Yeah.
anatomy and how it functions. Less so in endometriosis. That's people are often very symptomatic from that, but that causes a lot of inflammation. Even if you have small little deposits, it's really irritating. It can cause that inflammation within
Yeah.
your body, which can impact fertility, obviously, because one of the treatments for infertility due to endometriosis is surgery to try to
That's
help
right.
that. I don't know how successful it is. You probably do, but anyway, so really important to think about your past medical history when you're looking at your fertility and infertility, and that's something that your care provider will talk to you about. And so we're asking you because we need to know if those might be the causes, not for any kind of naming, blaming, anything like that. There's no judgment. We just need to know if any of those issues have happened to you in the past, because that changes how we can help support you in your journey.
I would like to just add, since we're on that topic of medical history and the importance of medical history in ruling out some of these causes, is just some other medical conditions that aren't necessarily related to tubal factor infertility, but just other medical factors that could put you at increased risk for experiencing infertility in general. And if these things show up in your history, there would potentially warrant like an earlier referral for infertility. So we already talked a little bit about endometriosis. So anybody who has a history of endometriosis, even if it's mild endometriosis, it's worth having a talk with a specialist sooner than later. And again, if you've had any pelvic or ovarian surgeries in the past, even as a child, like there's all these weird and wonderful things that happen when we're children, and sometimes you get this really big ovarian cysts or masses that get taken out. And so any surgery on your uterus or your ovaries at any time in your life, if you've ever had a family history of people having early menopause or premature ovarian insufficiency, then that would be a reason to seek out earlier treatment. And if you had chemotherapy or radiation treatment for cancer anytime in your life, those are other reasons why you should get seeds sooner. Just because we do know that chemotherapy and radiation can sometimes be toxic to the ovaries and can deplete their number or deplete the quality.
Awesome. Thank you.
Is this pain I'm feeling in my pelvis normal? Should I do genetic testing for chromosomal differences in my baby? Is it safe to go to the dentist while I'm pregnant? Doctors and maternity specialists Sarah and Alicia are here to empower you with even more knowledge so you can have the best pregnancy, birth, and postpartum experience you can. Presenting the Pregnancy to Parenthood podcast, a new series of informative episodes geared week by week toward whatever trimester of pregnancy you're in. Tune in weekly, following along relevant topics as you move through pregnancy, or just binge listen and come back to the episodes you found most helpful. Access the full series for a full 2 years and listen to it on your own time. To learn more, go to www.shefoundhealth.ca or click the link below.
So we talked a bit about tubal, but why don't we talk about pelvic or uterus? I know there's quite a few uterine things that can impact fertility.
hmm So uteri, I don't know, I never know if uteri is the right way to refer to more than one uterus. They're funny little things. The way they form in our bodies when we're embryos, basically, is they're two separate tubes and they fuse together, and then they have a divider in them, and that divider disappears. It sort of resorbs. And that's how a normal uterus is formed. And any failure of that whole process can happen, actually. And we get lots of different varieties of that. And so we can go anywhere from having a completely normal uterus to having two separate uteruses with two separate cervixes that do not communicate with each other at all. And that's really rare, but it does happen. And there's a wide variety of anomalies, for lack of a better term, from each of those ends of the spectrum. Sometimes they don't impact fertility at all, and sometimes they can be problematic. And again, this differentiating between these could be an entire podcast on its own. But just to say that there are some abnormalities that can increase your chance, your likelihood of infertility, and one of those would be having like a septum in your uterus. Just because the septum, this is where that little wall between the two fused uteruses doesn't completely go away, and it's not really functional like uterine muscle tissue, so it just doesn't. If an embryo implants on that, it just doesn't do what it's supposed to do. It doesn't make a nice placenta. It doesn't allow for a good growth of a baby. But if you didn't have a septum, but you actually had maybe two, like a bicornuate uterus, for example, where both of you have two sides of the uterus and they communicate with each other, but they're both fully functional uteruses. They're just separated a little bit. That doesn't impact fertility at all. It definitely has implications later on in pregnancy, but it doesn't actually impact fertility. So it is really important that we know about it and that we rule it out for anything so that we can pass that on once you're pregnant to your pregnancy care provider, and then they have that information.
And it's not always as easy as people would think to get a sense of what shape the uterus is. And oftentimes we have no idea with people who are pregnant who have this heart-shaped uterus, I call it, until they've delivered if we're at C-section. And then you have a feel of the uterus and you're like, oh, okay, that's why you had an early baby. And so sometimes even despite the best looking, we can't always get 100% of an answer. But yeah. What about fibroids? Can we talk a little bit about fibroids?
Yeah, so fibroids are also interesting. So fibroids are little benign growths. I don't like to call them tumors because people get freaked out about the word tumor, but they're benign growths inside the uterine muscle. And fibroids can happen anywhere from inside your uterine cavity, which is what we call like an intracavitary fibroid, all the way to the very outside, which is what we call a pedunculated fibroid. And we don't care about, from my point of view, we don't care about pedunculated fibroids. And they can happen, again, anywhere from outside of the uterus to inside of the uterus. We really only worry about fibroids from a fertility perspective if the fibroid impinges or touches on the endometrial cavity. So if it distorts the endometrial cavity or if it is inside the endometrial cavity. And even if it's inside the endometrial cavity, only if it's like more than 50% inside the endometrial cavity. So these are very specific types of fibroids. And if you have a fibroid, it's generally, I find radiologists are pretty good at specifying what the fibroid looks like, but it is one of the things that if you were to be referred to us with fibroids, we would do an evaluation of the inside of your uterine cavity to see if those fibroids impact it. If it doesn't impact the endometrial cavity itself, we don't usually worry about them impacting fertility. If you have really large fibroids that even if they don't impact endometrial cavity, again, these can have implications for your pregnancy and moving forward or the position of your baby when you're later on. Sometimes they can get really painful in pregnancy. Sometimes they can cause the baby to not grow as well. But again, from a fertility perspective, they're not that important. So sometimes if you have lots of large fibroids that are uncomfortable or that you're worried could impact your pregnancy, we can talk about treatments that potentially can help you. Maybe we can freeze eggs or we can freeze embryos. Then we can manage all of the issues with the fibroids in the uterus and then come back and put those embryos back in. That's something that we often do.
Yeah, and just one thing to note, people who have had fibroids removed, and that's done through the uterus wall, because uterus is a big muscle. So I think if it goes past, well, I usually just tell people that to expect is have a cesarean section. I forget what the actual rules are, but I think if it goes past halfway through your uterine wall, then it's recommended that you have a cesarean section for delivery, because then you have a scar on your uterus, which tends to be a bit weaker. And so there is a concern. So just keeping that in mind, if anybody's had kind of surgeries to remove fibroids that has gone through a decent amount of the uterus, that's certainly a recommendation. And you probably know the exact numbers of that. But we don't need to get into super details. People are used to me. Okay. Any other kind of pelvic factors, anatomy type factors that you wanted to chat about before we move on to male infertility?
I don't think so. I think that really, I guess the only other thing related to having blocked tubes, which is, I feel like we've gotten quite academic bringing up the fibroids and bringing up the bicornuate uteruses. So I'll just throw this in. Sometimes when you get blocked tubes, you get a big fluid collection in your tubes. This is called a hydrosalpinx. And these really do prevent you also from getting pregnant. And it's actually not just that they prevent the sperm and the egg from getting together because the tube is blocked, but sometimes that fluid that builds up in there could be a little bit toxic to developing embryos. And so if you have hydrosalpinx, we often recommend that you have your tubes completely removed, because once they build up that fluid, they'll never go back to being functional fallopian tubes. We know that. And even if we drain the fluid, it'll come back. If you are known to have these abnormalities on your fallopian tubes, we often just recommend surgery to have them removed before you do IVF.
Gotcha. Thank you. So why don't we jump onto male infertility or sperm problem infertility?
Yeah, sperm problems. I think that's a really good way to call it. When there's problems with the sperm, and you know what? I think sometimes people who have sperm who identify as male often feel like they're just a sperm donor in this whole process, and they are, because they just all they need to do is provide the sperm and then it works. But sperm makes
Hey, they need to
problems.
provide a lot of emotional support. They
They
have
do.
very,
They do.
very important roles once that sperm has been donated. That continues
Exactly.
on for decades and decades to come.
Very important. Yes. But that sperm contribution can be a problem in up to 40% of couples who are experiencing infertility. What do we look for in the sperm? What can be wrong with sperm? We look for general things on us when we're doing a sperm test or semen analysis. And so we look, first of all, how many sperm are there? And there's often millions of sperm. A normal number of sperm in a sample is about 15 million per milliliter or more. On average, a man has 1.5 milliliters. 1.5 is the cutoff for normal, but you can have more semen in an ejaculation. Yeah, that's a lot of millions of sperm.
Sure
They can
is.
be hundreds of millions per mil. Like, it's quite variable. So concentration is the first thing we look at. Second thing we look at it is how well do they swim in general. So we look at the percentage of them swimming. We want about 40% of them to be swimming. And then we specifically want to look at how many of them swim in a forward direction. And we only need about 32% of sperm swimming in a forward direction. The final thing we look at is, what do the sperm look like when we actually look at them together? We've got millions and millions of sperm being produced. They're being produced on an ongoing basis. And it's a very inefficient process. And so when we look at them, they might have abnormalities on their heads. They might have abnormalities on their tails. They might, in general, have abnormalities. We call this strict morphology. And the cutoff for strict morphology is 4%, which means only about 4% of sperm being produced look strictly normal. When we look at them, there could be a combination of all of these things. So you can have low concentration, you can have low motility, you can have low normal forms. If there's just low normal forms, which is actually quite common, I see this a lot, we call it isolated teratospermia. So anything less than 4% normal forms. If that's the only problem, it's not something that we really get very fussed about it. And there's actually been some talks that I've gone to recently by urologists who have said they don't really even care about the normal forms anymore if that's the only thing that's abnormal. But if the sperm is not swimming well, then it's not going to get where it needs to go. It has a very arduous journey. It needs to get through the cervix, through the cervical mucus, through the uterus, all the way through the fallopian tubes. And it basically needs to be waiting at the end of the fallopian tube when the egg is released, which is why motility is important. And then concentration is also important because in addition to swimming through all of that, if you leave hundreds of millions of sperm in the top of the vagina, not very many of them are going to survive the defenses that the vagina and that the cervix have put up to allow those sperm to get through. So you just need lots of numbers. And so we're concerned about concentration and motility for sure. And then the normal forms, depending on some of the other abnormalities we look at, there's that.
So, what might be some things that might cause abnormalities in the sperm? So, I'm thinking structural issues as well. We know there's a few kind of testicular and other issues. What are some of the issues? And we did a podcast with Dr. Ellen Forbes, kind of around male fertility and some of the things that people can look at, including cannabis use and those types of things in terms of optimizing male fertility. But certainly,
Right.
there's some physical things that can cause male fertility that can be modified by your friendly neighborhood urologist. So
Right.
varicoceles, et cetera, correct?
Yeah. So varicoceles, these are basically like the varicose veins in the scrotum. And what these do is the blood flows into the scrotum and it heats up the testicle and it oftentimes can decrease the amount of sperm and the motility of the sperm. And so varicoceles can be repaired by your urologist and sometimes it'll improve the sperm quality in that sense. Some of the other structural things that can't necessarily always be overcome are like if there's a history of an undescended testicle. So if you were born with undescended testicles or even one undescended testicle, this is a really important information to give to your doctor because it would necessitate an earlier referral or even just a referral to a urologist. So even if it's a person with testicles who's not currently interested in pursuing pregnancy, if they have this history, then they should be seeing a urologist to talk about that for the future. If they've had any significant testicular trauma or testicular surgeries, those are other reasons. Our friendly neighborhood chlamydia and gonorrhea again come into play here. So any history of sexually transmitted infections can also impact the sperm and their storage and their transportation. There's some other cystic fibrosis or a history or family history of cystic fibrosis. Sometimes there's some gene mutations that can cause that. And related to gene mutations like cystic fibrosis mutation, there's also what we call Y microdeletion. And these are things that we test for. And so there's a little part of the Y chromosome that is either missing or isn't functioning properly that just means men don't make sperm.
Gotcha. Fascinating. So I think our last topic is unexplained fertility.
So unexplained infertility, this is the hardest thing to deal with, to be completely honest. A lot of people want to know why they're not getting pregnant. And I want to be able to tell people why they're not getting pregnant. And I want to have something to fix. And it's actually, I can't even decide if it's worse to tell people they have unexplained infertility or to tell them that they have a problem that I can't overcome. I honestly don't know sometimes what's the worst. But unexplained infertility, the actual definition, I know I said it earlier, but I'll just repeat it quickly, is just at least having one fallopian tube that's open, having normal or near normal sperm and release, and having a normal ovulation that's happening every month. So if you have all these things, we can't necessarily give you an explanation. There's a lot of other obviously things that go into successful pregnancy, and there's like fertilization, there's the early development of the blastocyst, there's implantation and ongoing development of the embryo. And unfortunately, there's not a lot of tests that we can do to look at those kind of things. So sometimes one of the most successful treatments for unexplained infertility is in vitro fertilization. And I think we're going to talk about that in another series or podcast in a series. But when we do in vitro fertilization, we're able to gather a lot more information based on fertilization rate, how many of the fertilized eggs develop into embryos, how many of those embryos, how the embryos look. And that gives us a little bit more information. So sometimes people with unexplained infertility, they go on to do IVF and their IVF is very successful. And we still have no explanation, but it doesn't really matter because their IVF was successful. But sometimes we get these couples who go through IVF and they have IVF failure and maybe there's fertilization failure or maybe there's egg quality issues that we weren't expecting. All of these things that we have no test for them. And really the test is, let's do IVF and see what happens. This just goes to show us that no matter how much we know up till this point and how much we can do to make a difference, there's still probably just as much, if not more, that we don't know.
I can see why you have a full-time job.
Yes, it's a lot of thinking to do.
Okay, so we covered lots today. We focused on the causes of infertility. As we said, the person who produces the eggs fertility, the person who produces the sperm fertility, and that unexplained fertility. So thank you, Dr. Mills, for joining us today. If people want to get a hold of you, they can hunt you down at Olive Fertility, Victoria location. And you've got a
Mhm.
new Instagram site. Remind us what that is.
I do. Thank you. It's dr.ginevra.mills. And yeah, I'm looking forward to having some new followers. I just got into the world of professional Instagram, so I'm excited.
Perfect. We'll check you out and we'll post some of your posts. Is that the right term? I don't know. Sarah does most of that Instagram stuff. Awesome. And we look forward to our next topic, which is going to be, so we've talked about the different types, but how do we actually find out what type of infertility people have and what do we do about it? So that's our next topic. Really excited to chat about it.
Great. Thanks so much.
Thanks for listening. Make sure to check out our website at www.shefoundhealth.ca and to sign up for our community for weekly bump blasts. Make sure to check us out on Instagram or Facebook at she.found.motherhood and head on over to your favorite podcast app and leave a review and a 5-star rating. If you enjoyed this podcast, take a pic of yourself listening to it and share it on social. Make sure to tag us on it so we know to keep making them.